Hello and welcome to the VBAC Home Birth Stories podcast. My name is Ashley Winning and I'm the founder of the Motherhood Circle and the creator of the Journey into Motherhood program. Are you wanting to learn more about vaginal birth after cesarean section and find your confidence to birth the way you feel is the best and safest for you and your baby? Spending too much time worrying about the what ifs and questioning if your body is capable of vaginal birth? Well, that's about to change. This podcast is for women wanting to learn about VBACs, especially home births, and for professionals who want to learn more about how to support VBAC women home birthing. Nothing is off the table. I invite you to connect with yourself, find your own voice and strength to create this pregnancy, birth, and motherhood experience you desire. You totally deserve this. If we haven't met before, let me tell you a little bit about me. I'm a mother of two, I'm a doula, a motherhood guide, and have had 2 unplanned and unneeded cesarean sections. And I'm planning my first home and vaginal birth, so it'll be a home birth after 2 cesareans. I'm here to support you along your journey to discover and create your positive pregnancy, birth, and motherhood story. So feel free to reach out at any time if you want support. Now let's get started. Hey, me again. I just wanted to let you know that I've just created a brand new Facebook group called VBAC Home Birth Support Group, where you can connect with other like-minded mothers who are looking to have a VBAC home birth as well. You can find the link in the show notes and I look forward to seeing you there. Hi, Rachel. Thank you so much for coming on today. I was just having a chat with you and sharing how I have a bit of a lady crush on you and how I've been following you for a couple of years now and had the pleasure of meeting you at the Sydney Doula Conference. So it is such a pleasure to have you and your knowledge on the podcast to share some insight and wisdom with the audience today. Would you please introduce yourself to the listeners?
Okay, so I'm a midwife and I'm an academic researcher, writer and speaker, and you've got experience of working as a midwife in the UK and Australia, in hospitals and at home, and I guess the last 7 years of my practice was just home birth practice in Australia, and caring for a lot of women who are choosing VBAC, choose home birth for all the reasons that I'm sure you're aware of. So I've cared for women planning home births with VBAC. And I guess my area of real interest and speciality in terms of writing and research and speaking is the promotion of physiological birth, so instinctive physiological birth, and what midwives do during birth to promote that or not. And really women's rights in maternity care and women's rights as in rites of passage, so rights legally, but also their rites of passage in childbirth.
All really important topics and basically my obsession over the last couple of years. So I'm really excited to get on and talk about some of these important topics as well. So I guess we'll just dive right into it. Let's explore what I call undisturbed birth or instinctive birth. What do you prefer to call it?
Oh, well, I tend to use the term physiological birth and
Sure.
an instinctive birth, but people call it all kinds of things. I tend to keep away from normal birth because I don't think that's helpful, because none of us are normal, and a cesarean section is normal. It's actually not normal to have a physiological birth in modern birth maternity services, and physiological refers to an organism functioning in a healthy way. So I guess that's an instinctive is the instinct, so I guess either will do.
Yeah, I love those. I think that makes it really clear. I love instinctive birth and physiological birth, the way we were born to do it, and what mammals are doing out there every single day, how we were designed to birth.
Yeah.
So what is physiological or instinctive birth for the audience to understand a bit more?
So this is, as you said, just our mammalian blueprint. So we have evolved to birth instinctively, to know what to do and what behaviors are needed to get our babies out and to then protect the babies. That's why we're still here as humans. And then, so that's something that all women have evolved to do. But we live as humans in this culture and society that builds all kinds of kind of belief systems around things, practices and rituals around birth. So really, since the beginning of time, humans have also enacted rituals around birth, which have influenced birth. So I guess nobody really has a completely undisturbed physiological birth, because unlike mammals, we have this neocortex and we have these complex social groups which alter how we approach birth.
So that's more when you're introducing support people or people in your space. Is that what you mean, versus mammals who may move away and birth completely alone?
Yeah, and it's kind of interesting because there's a lot of kind of debate around why is it that human females birth with other females and other mammals don't do that. And actually, I've been researching this for my book, and I headed off on all kinds of tangents on all kinds of animals. And it's really interesting because so the animals that we're closest to are chimpanzees and bonobos.
Mm-hmm.
And chimpanzees birth by themselves, so they go away from the group to birth. But chimpanzees live in social groups that are really quite volatile.
Mm-hmm.
There's a lot of the male chimps are dominant,
I've
and
seen. It's a bit
yes, and
scary. Like
they're
if you
pretty
don't follow the
nasty.
rule, you're out and then you're dead.
They're pretty nasty to each other. And
Yeah.
for a female, that's quite a threat to her and her baby. Babies will
Mm.
be killed if potentially. Whereas bonobos live in these really kind of socially cohesive groups, which are kind of almost like matriarchal or matricentric. So the females have a lot of power in terms of because it's all about kind of how they interact. And so I guess they're most, I'd like to think, well, they're probably not, are more similar to humans in their social structure, in that they're actually nice to each other. And there's lots of sex with bonobos, but that's a whole other story. But bonobos actually birth with other females. So when they birth, females gather and kind of protect them, but also help kind of the elder females enact little actions to show the mother what she needs to be doing as the baby's coming out to catch it. So they have quite social births. So I don't know, the jury's out as humans what we've evolved to do. But we have certainly taken up a social model of birth, and as far back as we can go, women have sought the company of other women while they give birth.
That helps clear up some questions in my mind, because I've been reading a lot about undisturbed birth, and I'm like, if you have, a midwife or a doula or someone present, how does that kind of work out in your mind? Or do you have to do it alone, kind of thing? But so it makes me feel a lot better to know that it's quite normal and natural, and probably why I'm feeling like I definitely want to have people around me as well. Did you, out of interest, this is totally off scale, but did you come across how elephants birth? I know that the women stick together after, and then the grandmothers and the mothers teach the new mothers how to kind of look after their babies to keep their babies safe. Did you find anything on elephants for elephant birth?
Yeah, I did.
Did
So
did they birth alone?
no, so elephants
Mm,
also birth with other females, and it's more of a so when the female elephant is birthing, the other females surround her and kind of face outwards to
mm,
so that it's more like a protective. And then they all, once the baby's here, they all run, touch the baby and smell the baby and kind of welcome the baby into the herd, and then bring the baby back in kind of as a group protecting it.
because I've been watching them, and I'm just amazed at how they stick together, and they're a real little community looking
Mm.
after everyone. So, cool. Thanks for sharing that. So we've touched base on what a physiological or instinctive birth is, I suppose, on a bigger scale. What are the benefits of this kind of birth? Because we are often told about the risk and the benefit. We're not even told about benefits, but we're often told, especially as VBAC women, the risks of a VBAC birth, but we don't ever get told about the benefits when we're fighting, in the system, I suppose, inverted commas, to have a spontaneous delivery, or, less interventions and these sort of things. We never get information on, the benefits of a physiological birth. And it's a little bit disturbing to me and a little bit crazy, it interesting, I suppose, that it's so hard to have this kind of birth in the hospital setting, which is why so many women, go on to choose a home birth. So what are the benefits of having this kind of birth?
Well, I mean, I guess the way I think about birth is a little bit of a flip from what the kind of medicalized mainstream maternity system thinks about birth, which is that and it all it's way, goes back historically, where the maternity system was built on the idea that women's bodies are dangerous, which comes from kind of religion and state way back, that women's bodies are dangerous, and that by managing and controlling the woman's body, you can reduce the risk. So the concept is that the woman is the danger, and the things we do to the woman reduce the chance. So with a VBAC, the fact that there's a scar on the uterus is really dangerous, and we need to do all these things to the woman to reduce the chance that that scar is going to burst open, and which is very, very unlikely, but that's the focus. Whereas I think it's more helpful to flip it and kind of think of, actually, the vast majority of the time, physiology works. Sometimes it turns into pathology, and yes, we need intervention for that. But if we consider what we do to the woman as the risk, it completely changes practice. So with a physiological birth, what you're doing is you're promoting and supporting the physiology of the birth, which is the unfolding of a healthy, instinctive birth process. And everything you do and say is an intervention. So you need to then think about it as, am I about to intervene in a good way? Because you can have good interventions if as you were saying, you feel like you want to have women around you. So having women around you is an intervention from physiology, I guess, but it can be a positive one. It can help you be calm and feel safe and supported. Therefore, physiology actually functions better because you're not stressed.
Yeah, and it's interesting that we talk about
Considering
intervention.
the
Oh, sorry.
blueprint and how you can support that.
Sorry, you just cut
Yeah,
out
no,
there,
carry
so I
on.
thought you took a break. Sorry, the internet just cut out there.
Oh,
Sorry, I was just going to tune in and say, it's interesting that you talk about interventions in a good way as well, because when I wanted to have a water birth or at least labour in the hospital pool, I was told that was an intervention. But as far as I could see, it was a good intervention that could have been used to help me labour and that sort of thing. So would you consider a birthing pool intervention?
I think anything that's an intervention from that basic mammalian, head off into the forest and give birth is an intervention. But as you say, some interventions actually support physiology. So water birth, there's enough evidence to show that for women who choose water birth, it has positive outcomes. It actually promotes and supports physiology. It relaxes women. It enables them to move more effectively. So that's an intervention that's effective and promotes physiology versus a lot of interventions that actually disrupt physiology.
And what are some of the other benefits of, because I know there's so many benefits of undisturbed or physiological birth. What are some of the benefits that we can rattle off here for our listeners today?
Oh, so you've got the kind of short-term benefits in that if a woman's birthing physiologically and undisturbed, then you've got better hormone functions. You've got increased oxytocin, which makes the contractions more effective. She will enact. So there's a relationship between mother and baby that's often forgotten in the medical model. So the mother will regulate her contractions according to the needs of the baby, and respond to the environment around her and what the baby needs. So you've got that kind of protection of the baby because the physiology is functioning. So you're less likely to get a stressed baby during a physiological birth. And then the woman protects her own body when she's pushing her baby out and enacts behaviors that reduce the chance of her tearing. So she's more likely to have a healthy outcome of her perineum and of the baby because she oxygenates the baby. And then, just that whole microbiome seeding, the epigenetics of labor, which is we're just starting to get research, and researchers looking at how important. So we know epigenetic changes happen in pregnancy. So what happens is the mother's biology and physiology send messages to the baby that alter the baby's DNA expression. So it kind of switches certain genes on and off. And even if that baby is not genetically hers, so if it's a donor egg, the woman that the baby's growing in will actually use that material, that DNA material, and craft it according to her environment. And there's a lot of that going on during birth. So you've got some really important set points happening for the baby. So the set point for the oxytocin system in the baby, the baby's, needs to have a bit of stress because that actually initiates its breathing and its transition into extrauterine life. So there's all these things that are happening for the baby and for the mother. And then so long term, we know that physiological birth is associated with better long-term outcomes for babies in terms of better breastfeeding outcomes. Heart disease is associated with interventions such as cesarean. There's a whole range of things that we're only really looking at because previously we've just looked at, does the baby come out alive? And we're only really now looking with research about, well, that's one factor, but what happens after that?
Yeah, interesting. And I mean, obviously there's so much to talk about and it goes in so much more depth than, we can even get onto today. But what about benefits for the mum? Because, I feel like birth is all about a healthy baby, a live baby. But what about the benefits for mum of, having a physiological birth, if there are any?
Yes, there are health benefits in terms of she's more likely to have a good outcome, less likely to tear, less likely to hemorrhage, less likely to have a complication. But also we need, whenever you look at intervention and things like induction and cesarean, you need to compare them to what the default is. And labor is not just about getting a baby out.
Mm-hmm.
There's a whole load of things, changes that happen within a woman's body before labor to prepare her for labor and then during labor that really set up how she feels and then integrates that after the birth. So a woman who's had a physiological birth by the time has got extremely high levels of oxytocin, which is the bonding hormone.
Mm-hmm.
You've got high levels of prolactin, which are the milk making and mothering hormone. She's just had a massive burst of adrenaline as the baby crowned, which kind of, as you come down off adrenaline, it sets up kind of falling in love. They've actually done experiments where they scared people and then got them to meet a handsome stranger.
Wow.
And found out that if they'd had an experience where they'd had an adrenaline boost before they met this handsome stranger, they were more likely to fall in love. So you've got that happening. And then you've got a baby coming out, and the mother and baby are flooded with beta endorphins, which is kind of an opiate, which is a dependency hormone. So you've got this combination that makes the woman feel euphoric, and the mother and baby, I call it the enchantment phase, where they just are falling in love. And you can't replicate that. You can try, you can certainly get oxytocin going post-birth with skin-to-skin contact, but that sense of physiological empowerment that women describe after a physiological birth is not something you can replicate through any other kind of birth. And that can be really confronting for women who have not experienced that. And it's not, I'm not saying, I've had nursing students like walk out of sessions and get very upset with me when I say this, saying, well, I love my baby just as much. Absolutely, you do, because we're animals with a neocortex. We can know our babies before they're born and we fall in love with them anyway. But that physiology, if anybody's experienced the difference, and I myself have experienced the difference. I have two babies. One was not a physiological, was a vaginal birth, but artificial oxytocin. The second birth was physiological, and I can only describe it as a physical euphoria and connection to the baby was completely different. And this is what women describe, and then that goes on to assist you to set up the relationship with the baby. So my baby, if I had my first baby, if I'd had my second baby who I had a physiological bond with first, I'm not sure I would have survived, because she was a really difficult baby that on an intellectual level was very hard to love, because she was extremely demanding, really difficult, and to not sleep, all those things. Luckily my first baby was easy. But and it's not that I love either of them more than the other, although my daughter does describe herself as my oxytocin baby and wind her brother up about that. But we need to acknowledge there's an actual physiological connection that happens between mother and baby that happens after a physiological birth, that if we disturb it, there's risks involved in disturbing it.
And I suppose this goes on to then possible birth trauma, possible P&D, this experience where the delayed bonding with the baby goes on, and then mothers are berating themselves, thinking there's something wrong with themselves, when the actual bond and that burst of love can take a lot longer because they've missed out on some of those experiences and hormones.
Yeah, so then we need to help women to reclaim that in other ways, but that initial experience can't be reclaimed.
No.
And it's also risk management. With a physiological birth, one of the most dangerous times of birth is the placenta, getting the placenta out. And we kind of forget that initial enchantment phase where all those hormones are flying around and mother and baby are interacting is what gets the placenta out. So
let's talk about that, because my biggest fear, because of all the movies I've seen, of women basically passing away during childbirth, is always at the placenta stage. And so that was always a huge fear for me. So I read articles on your website in regards to a physiological delivery of the placenta and how it was beneficial if you have a physiological birth, but maybe not as beneficial if you were in a hospital setting or a setting where you didn't have an undisturbed birth. And so I was kind of trying to absorb as much information about the whole placenta, trying the benefit of that and how to, make sure that the placenta comes out naturally and that sort of stuff. So it's interesting that you say that. Could you expand a little bit more on, how to get the placenta out naturally and the benefit of, a physiological birth?
Yeah, so if your body has birthed your baby physiologically, then it's actually much safer for it to birth the placenta physiologically. And the research around actively managing the birth of the placenta after a physiological birth is that it increases your chance of hemorrhaging, which is no surprise, because if the body's functioning really well and has birthed a baby and you intervene, you're going to disrupt that really healthy unfolding of physiology. So once the baby's born, there's still the big job of the placenta to come. And I feel that as a midwife, this is the bit of labor that I don't like either, because it's the sacredness of this part of labor is forgotten, because in the West, we're really good at managing hemorrhage. We've got very high rates of hemorrhage, but we manage it really well, and we don't see women die from hemorrhage, very, very rarely. So it's not something we're scared of. And for women in our kind of cultural references to birth, the placenta just doesn't exist. Women give birth on TV and there's no placenta. So that phase is not really given that sacredness that it needs. So once the baby's out and you've got all these high circulating hormones, the mother and baby, and this is really important, mother and baby work together to get the placenta out. So the release of oxytocin. So what tends to happen is there's a pause after a physiological birth once the baby's out, because the baby will be usually born onto the floor between the mother's knees if she's not in water. And she'll just have a pause because she's just done something huge. She's just been in this really altered state of consciousness until the adrenaline boost of transition, which kind of brings her back to then push the baby out. And then she's had another boost of adrenaline as the baby's head crowns, but she's still in this real kind of getting her feet back into the world. So there's a pause, and the woman will kind of stop and gather herself before she then looks down at her baby, who is making that transition with the support of the placenta, and then she'll touch the baby, talk to the baby, and then eventually gather the baby up and put the baby on her chest. And then once the baby's on her chest and the baby's nervous system starts to settle in response to the smell of their mother and the fact that then they now feel really safe because they're protected on their mother's chest, they start this little dance, and the baby can smell. So the Montgomery glands on the nipple send out a smell that is very similar to amniotic fluid. So the baby recognizes that it's in the right place, this is the right person. And the baby will start to bob its way to the nipple and kick its feet on the uterus, which makes the uterus start to contract again. And the baby's hands, it does this kind of grabs the nipple and then pulls its hands back to its face, where it then licks its hands, and it's starting to get the taste from the nipple onto its hands and into its mouth, and all of that is learning, but it's also stimulating the mother's release of oxytocin, which makes her uterus contract. And this is a long time. We're talking about minutes, quarter of an hour, maybe half an hour, as the baby does this dance towards the nipple and interacting with the mother, making the uterus contract, making the placenta come away, and then contracting down those blood vessels so that the bleeding stops. So it's really important to not disrupt that. And it's really hard as a care provider when you're going, oh, is she going to bleed? What's going to happen? To not disrupt that. And there's a lot of assessments go on around that time. So in hospital, and babies being, people will not just let the baby do the part of the baby's learning to breastfeed is attaching and detaching from the nipple, and that stimulates oxytocin as well. And the baby needs to do that to imprint how to attach to the nipple. So it's not that it's being useless and can't get on. So we don't need to jump in and stick the baby on the nipple. It's actually part of the learning of get on that way, come off, that's imprinted, get on that way, come off. All of that gets the placenta out. That is how the placenta comes out. So any disruption of that will increase the chance that the woman will bleed.
So interesting, because half an hour, 45 minutes, that wouldn't normally be allowed in a birth, I suppose, as like a kind of almost like a panic to kind of get that placenta out. So if we do allow this to happen, we allow babies to crawl to the nipple and, do part of the work for us, and we're calm and we're relaxed and we're enjoying our situation, what is, I'm going to say normal in inverted commas, but, what is normal for placenta birthing time, or what can be normal, and what are, some of the benefits of allowing that versus some of the risks of going over that time frame?
Well, hospitals tend to say the placenta needs to be out within 45 minutes or an hour with physiological birth of the placenta, which is actually, I don't know where they get that from. I think they just made that up. There isn't any real evidence to say that it should be out at any particular time. But it would make sense if you look at the physiology. And in my experience of attending births where women are having physiological births, then the placenta is usually out within an hour. Some women it's not, some women it's hours. But you are asking questions. If you're coming up to the hour and there's been really good interaction between mother and baby, and you've seen that, the babies and mother have been doing all of those behaviors that get the placenta out, and there's still no placenta, around about an hour, I would be questioning, I wonder if it's just out and it's sitting in the vagina, and if we just help the mother to sit upright, it'll slide out, which is the usual scenario, that it has come out. It's just she's reclined and enjoying the baby, and it's just sat in there. So I think you start questioning, or I would start questioning around about an hour. But then you've got to be careful, because it's not a stressful questioning, because that's going to actually reduce oxytocin and increase the chance that the placenta is not going to come out.
So you have a bit of a difficult time as a midwife trying to not disturb it, but also trying to keep the situation safe.
Yeah, because you do need to keep an eye on, but really from my perspective, everything I need to know, I can know from looking. I don't need to touch a baby to know if a baby's made a healthy transition. A baby who is kind of a nice color, who is moving about and looking for a breast, is clearly well oxygenated, and their heart rate will be normal, because otherwise they wouldn't be doing that. So I don't need to touch the baby or interfere in that way. And with the mother, you can have a look, but I have to check myself. I had my year of placentas, I called it, where I had a year of women having, luckily nothing too awful that we couldn't manage, but a few women had a big bleed, women had a retained placenta, so I was a little bit stressed around placentas. So I had to just say to women, look, this stuff's before they had their baby. this stuff's been going on, so this is my issue. So
Mm-hmm.
if I remove myself from the room, I'm dealing with myself, not you.
Mm-hmm.
And I would do that, I would say if they've got a partner with them, a woman is not going to bleed to death without noticing.
Mm-hmm.
She's going to be the first person who says, I don't feel well, or there's lots of stuff coming out of me. I would actually just leave the room and say to the partner, or the mother, I am just sat outside of the door, and if you need me, give me a shout and I'll come straight in. And usually, they'll give me a shout and say the placenta's out.
Oh, that's really good. When you were talking about the baby and the baby becoming aroused and waking up, I've seen a lot of birth videos where the baby may take a couple of minutes to kind of come to. Would you consider that quite normal?
Yeah.
Yeah.
And you've got to kind of think about what else is going on for that baby. So if you've got a healthy baby and the placenta's still attached and functioning, then the baby has time because the baby's still getting oxygen. So it can take a little bit of time for it to come around. Need support if the placenta is not functioning. You can see that by looking, if you've got a cord that's full of blood, then the baby's getting blood. If the cord's empty or the baby's really pale coloured and floppy, that's a different scenario. But usually all that's happened is the baby's, especially water birth tends to be, because what makes the baby breathe is actually a reduced oxygen, which increases the carbon dioxide in their system just before birth. And the end of birth is pretty stressful in a good way, in that it gets the baby ready so that when it comes out into the world, there's a sudden change in temperature, there's a sudden change in environment, and all those things stimulate the baby to breathe. And in water birth, the baby goes from lovely warm water into lovely warm water,
Mm-hmm.
and often is just like not even aware that it's here yet. And so they come out, they can be asleep, and it can be really challenging the first time you're learning to support women with water birth as a midwife, because you go, oh my god, this baby's not breathing. But if the cord is underwater, so it's warm as well, so often the cord will pulse for a lot longer, so the baby doesn't have to transition as quickly, and you're just waiting for this baby to work out that it might need to join us in this world. And there shouldn't be there isn't any rush.
Interesting. And I'm just thinking about your because I've heard you talk about these amazing stories about being present at women's births. I wanted to kind of pick your brain in regards to having a midwife present, but also finding a midwife having that conversation and being able to identify with a midwife who is going to have conversations with her clients about, this is my baggage, I will excuse myself from the room, or I'm very hands off. How can we find someone who is going to be hands off and support that sort of birth?
Well, I guess it's a relationship, isn't it? So the midwife has to be honest with the woman about who she is, and that's when you have I guess when you're lucky enough to be able to choose your midwife, that's part of the choosing, is you meet with them and you actually have these conversations right up front before you get into the relationship. And I learned this very early on in my private practice midwifery, because I'd done home birth kind of in the NHS in England, about being really honest with women about who I am, because otherwise how can they choose the right person? And I'm not the right person for a lot of women, and I am for others. So I would be really explicit about, this is who I am, this is how I practice, this is my kind of belief system around birth. Does that work for you? And it's absolutely fine if it doesn't, and I can maybe find you a midwife who's a better fit. So it's about having those conversations, and maybe having a conversation with women who have had that midwife as their midwife, if you can. That's often a good tell about how that midwife practices, and asking the midwife for stories about how did you things that are important to you. So if you're having a VBAC, say to the midwife, do you do anything different when you're caring for a woman with a VBAC? Is there anything that you pay particular attention to in that scenario, and how would that influence my birth? So it's asking questions, but you kind of also relying on the midwife to know who she is and be honest about who she is.
And I guess trusting your intuition as well, and how you feel with that person, I suppose, comes into play as well.
Yeah, absolutely. And if you're getting red flags through the pregnancy, then listen to them, because once you birthing, there's not much you can do about who's in your space.
Mm. And the next question I wanted to ask you was, what is the differences between a VBAC labour and a non-VBAC labour from a care provider or support perspective? Because it's become very obvious to me with my conversations that different midwives or different healthcare providers have different views or biases on different things, high BMI, VBAC, all these sort of different risk factors that obviously from their experience or from their training that they bring into the birth. So what are some of the differences between a VBAC and a non-VBAC?
It depends on the care provider as to how they approach it, which is why you really need to be asking the care provider, because we all have, there are certain things that I am very stressed about in terms of, obstetric cholestasis is a really big stressor for me.
What's
It won't
that?
be for pretty rare, but where women get kind of really itchy in pregnancy and they have liver abnormalities. But so a lot of the way that we feel about things as midwives is based on our previous experiences and the stories we've been told and all of our baggage. So for me, VBAC, I have not had a bad experience with VBAC. So I am biased in that, for me, things like uterine rupture, I have only seen with women who are having induction with syntocinon with no uterine scar. So I am more worried about syntocinon with a uterus than I am about a woman labouring who has a scar on her uterus, because in my experience, there isn't I haven't experienced a catastrophic outcome. It's always been a good outcome. From a perspective of caring for women who particularly choosing home, the hospital is a whole other, it's a whole other thing, because you've got to negotiate the system for the woman. But with home birth, it's always helpful to really understand the woman's previous birth experience, and really, have a really good conversation and understand what it is she learned from that experience about herself and about care providers, about birth, what her concerns are going into this next birth. Because the difference I find with women who are having VBACs versus women who haven't had a previous cesarean, this is their first VBAC after their cesarean, is that there's tends to be more self-doubt. And that comes up in labour. So you're kind of ready for that self-doubt. And depending on what happened with a previous labour, if they, and I'm doing this in quotes, got stuck, i.e. there was a particular point in labour where everybody lost their patience and they ended up having a cesarean, that's in their mind. So women will sometimes ask for vaginal examinations, which I wouldn't normally do in labour, because they kind of want to know that their cervix is past the point where it allegedly got stuck last time. So there's a bit more work to do with women who are having VBACs, not around the physical risk aspect, because actually, that's really tiny. And there's so many other risks that are higher than that, even physically. And, these women have good outcomes. They are more likely to have a vaginal birth than a woman having her first baby. It's to me, not a significant risk to me. It might be to the woman a 0.2% risk, but for me, it's not. I'm more worried about the woman's emotional experience and how that might come up in labour and how we can work with her to support that.
Are you looking for any physical indicators or anything for VBAC women when you're supporting them in a home birth?
Yeah, so your threshold's a little bit lower for strange patterns of labour. Women have very individual patterns of labour, and stop-start labours are fairly normal. But if a woman's had a previous cesarean, you're a little bit more concerned about a woman who looks like she's in established labour and then stops, and then gets into established labour and stops again, because that can be a sign that the uterine muscle isn't well coordinated, which can suggest something's happening with the scar. So I think thresholds for being concerned about that are a little bit lower. And with the really lovely thing about a woman having a physiological birth is she will know if there's something going wrong. And she's in her body, she's feeling what's happening. If there's any, it's not like a woman who's got an epidural who can't feel that she's getting pain across her scar. So, the woman will feel it and she'll tell you. Yeah.
That's what I've actually heard myself, because I went on a mission to connect with as many women who had had uterine rupture in a special group. That there were a lot of women. It was a special scars group, so there were a lot of women with these special scars. So I asked them to share their stories, and they knew something even when they indicated it to the healthcare professional. Often they were dismissed in their feeling. They couldn't really identify what was happening, but they knew something was happening. And so I found that really important, that, the woman was the one who mostly, 99% of, well, pretty much every case I'd heard had identified that, even if it was, I just don't feel right, or I've got some pain in my neck or something like that, that went on to be discovered later on. So that was really interesting. And another benefit, I suppose, of undisturbed or physiological birth as well, when a woman, is listening to her body.
Yeah, and I think this goes back into antenatal care, is really the maternity system has set up antenatal care to be really grooming women to see the external expert as the expert in their body, and to see medical technology as the savior. And that's kind of what we do right from the beginning, when really antenatal care should be about reinforcing the woman's expertise and the woman really connecting into her. The baby is inside her. This is her body. She is the expert here, and her believing that and connecting in with that and really listening to herself. Because you're right, the number of times if there has been a bad outcome, I'm not just talking about VBAC here, when we talk to women afterwards, they will say, I knew there was something not right. And often they don't speak up because they think, no, like I wouldn't, surely they would know if there was something wrong. And all the clinical signs are normal, but the woman knows. And it's the same with all this, monitoring your baby's movements thing that everybody's getting really excited about. Is that you don't need, if you're connected with your baby, you will notice when there's a change, and you need to really listen to your instincts, because that's what you're going to have to do as a mother.
One of the, I 100% agree with that, and I was just beaming when I was listening to you tell that as well. But I put a recent question into the VBAC home birth group and asked them, the audience, what they wanted to know the most. And I'm just thinking, as we're talking about the woman knowing when there's something wrong, I had heard you speak about the woman knowing eventually, what position to be in and what movement to be in. And I'm recalling my last labour, which was my first labour that I ever had. And I felt I wasn't 100% dilated, so I was 8 centimetres dilated. I had a cervical lip, and baby was ROT position and senolytic. I had all these medical terms thrown around at me, but I felt like after they had broken my waters, I felt that I needed to push. And I have spoken to a lot of other women who have been ROT, and they have also explained that they felt like pushing earlier on. So I, in my body, was like, I need to push. I need to feel like I need to push. But when I was saying it, I was dismissed and told, in my mind also, I'm saying, you're not even 10 centimeters, so you can't push yet, But I felt the urge to push. How do we know as women what position to get in and to trust ourselves for that position, and not kind of look to the midwife or someone who's in a support circle to kind of, what should I be doing, being that we are supposed to be the expert on this experience?
Well, what you've got to think about is where the care provider is coming from. So we're taught from textbooks that are based on birth in the early 1900s, where all women were strapped to a table and sedated, and babies were removed from them, so their cervixes had to be open to put the forceps on the baby, otherwise you'd tear the cervix. So that's where the idea that the cervix has to be open in order for the baby to come out. So that's when our understanding of birth, in terms of in hospital, how we're trained medically, came from. So as a care provider, you're taught that birth is like this mechanistic thing, because our understanding of birth came out of an era where the machine was just, becoming a big thing. So the body became conceptualized as a machine. And the idea was that the mechanics of birth is that this door opens, which is the cervix, and then a baby comes through, which is not true. That's not how birth works. And we're finding that out now through research, but this is too late because all the textbooks tell us that this is what's happening. So from the care provider's perspective, they're looking at the situation and going, the door isn't open, the cervix isn't open, so you mustn't push because you're not at the point where you're supposed to be pushing yet, according to the things I've learned. So the things they've learned aren't true. They're based on, a particular idea about birth that was certainly not physiological. And what we know about pushing, early, it's actually best not to know what the cervix is doing, that you don't get caught up in this, is that women will do it in particular when their baby is needing to rotate, which is what's happening when the baby's not in that anterior position. Any other position, the baby's head kind of hits the nerves in the near the rectum that make the woman want to push, and it happens sooner. And woman pushing actually presses the baby down onto the pelvic floor, and the pelvic floor acts like a pivot so the baby can rotate more effectively. So what's probably happening is that this is women's physiological response to needing to turn their baby, and then we step in with our textbooks that are actually incorrect and start telling the woman that that's the wrong thing to do when she can't not do it because the body is doing it. And it also undermines her confidence and her expertise, which has then impacts for the rest of the birth.
Yeah, definitely. And then, I know myself afterwards when I started learning more about birth, I thought, oh, damn, I should have just listened to myself. But when you're in that environment, you're not going to listen to yourself most of the time because you're in that environment because you're seeking outside support and, help. So thanks for sharing that. That was really insightful. I'm just reciting some of the stories that I heard you talk about in at the doula conference, and I'd love to for you to share some of the births that you've attended where you've had to hold yourself back and watch a woman instinctively birth, and in your mind you're saying open your leg, but you're saying no, Rachel, I won't do that. Can you share some of your special stories with us?
Yes, I guess it's my unlearning or my relearning, which really happened. Women have taught me everything I know about birth, really, that's worth knowing, has been taught through watching and listening to women, and just keeping out of the way during birth. And, I am a monkey mind person. Midwife thinking is probably quite apt. My brain does not stop, does not shut up. That's just who I am. But in birth, I've had to find a way of actually just being with what's happening, not being in control of it, and just being with. And the things that I've learned have then reinforced that approach. So, one of the techniques that I always talk about to other midwives and to students around, you have to know yourself and you have to know how to manage yourself. That's more important than knowing how to manage birth, because that manages it, the woman manages that. And one of my things is my mind is sitting there going, "Brother, is this happening? Is that happening?" And then I feel like I need to ask, or I need to kind of say something. And I've learned to just wait for 5 minutes. I look at the clock and I give myself 5 minutes to really consider whether or not, am I saying this because it's helpful to this woman and what's happening, or am I saying it because my brain wants to know something and it's about me? And usually by the kind of 5 minutes, I don't say anything because it was actually all about me. And also, I've learned that when you're watching a woman birth, what you think should be happening is not necessarily what needs to be happening. And I guess and I've told this story quite a few times, one of the most significant learnings in this was a woman who was a third baby, and she'd labored through the day, and then she'd stopped laboring through the day because she had 2 kids, and then when they went to bed she'd labor. So she did this for 2 nights, and this was the second night, and she was coming close to birthing this baby, and she just got into a position. She put her head on the floor and her bottom in the air, so it was actually upside down almost. It was really weird, and she was pushing. And me and the other midwife are looking at each other thinking, that's really stupid. Like that, how are you going to get a baby out upside down? And I really wanted to say, why don't you just try? Because I think that baby would have come straight out if you just got into a squat or got upright. But I resisted my urge to speak. And this baby eventually, because it took a long time, because it was going uphill, came out with a little gush of blood behind his head. And then the next contraction, both him and the placenta came out all in one, one
Wow.
little parcel. And he was a little bit kind of shocked and a little, he wasn't in fantastic condition. And it was funny because the midwife I was working with felt the cord and went, "It's okay, the cord's pulsing." And then the mom went, "Yeah, but what's that?" And it was the placenta was out.
Wow.
So the cord was still pulsing, but the placenta wasn't attached to her uterus, so the baby wasn't getting any oxygen from her. So he was a little bit stunned, and he came good after we kind of, mom had picked him up and handled him, and he came good. But so looking back, I think, because she hadn't had scans, I think that placenta was probably really close to the cervix, and the position she was in took the pressure off the placenta so that it could still get, perfused with oxygen just for that last bit of birth. So it made perfect sense after that, even though it looked, and there are countless experiences where women have done really strange things that I've wanted to correct, when in fact what they're doing is absolutely perfect for what's going on in them. And they might not consciously, that woman had no conscious idea about what was happening inside her. She just instinctively felt that she needed to be in that position. And then after the birth, the baby was grunting a little bit because he'd had a real difficult transition. And we were kind of going, "Oh, if that continues, we're going to have to transfer in." We weren't saying that to her, but the midwives were kind of keeping an eye on the clock and how long. And I was, and I started doing my kind of, well, if we're just fussing with him to reposition him on the mother. And the mother just looked at me, she went, no, so it needs to be like this. And she folded him up into a position that looked, I'm thinking, no, he can't breathe properly in that position. She folded him up like a little frog, and he just came good, started breathing perfectly normally. And it's like, okay, yeah, you actually do know a bit more than me.
That's so special, and such a special story to hear that as well, and to give that power back to the women as well, which is a gift that you're giving when you attend your births.
Well, the women always have that power. It's in them, and it's about kind of reflecting it back, because we're socialized as women to not believe in our power and to not exercise our power, because it's always there. It's whether or not we exercise it. And often what happens is, in structures like the maternity system, they're actually created to stop you from exercising your power and to allow other people to exercise their power more effectively.
Yeah, it becomes a bit of a battle sometimes as well, which is really hard. So it's really good to learn about this. I just wanted to ask you one question before we go. How can we achieve a VBAC physiological birth? What's some of the points? If you could give us some points on how we could achieve the best way to achieve this.
Oh, the best way. Okay, so it's to really consider what it is that you need, and that will be individual for different women, and it will depend on why you had the cesarean last time. If it was an elective cesarean, that's very different to a woman who labored for a long time. And so it's exploring your previous birth. What lessons did you learn from that birth? Because every birth is a powerful rite of passage, and during that rite of passage we learn really important lessons about who we are and what we need. So revisiting that birth, what is it that you needed from that birth? What did you learn about yourself, about your own power, and what you need in order to exercise your own power? And then seeking the environment and care providers who can offer that. That might be a home birth. For some women, they might say, no, I really wouldn't feel powerful having a home birth. It really freaks me out. I really feel like I need to be in a setting where there's medicine all around me, because that makes me feel safe, but I need to take someone in who can negotiate for me. I need to have a doula or a friend who can really kind of interface with the system to make sure that my needs are met. And just, trusting in doing what you can antenatally to build trust in yourself. And that's not, trust birth is a mantra that's often used, and it makes me a little bit uncomfortable, because birth can throw curveballs at you. Birth is like, that's why midwives evolved, because sometimes birth just does things you don't want it to do.
And it can be scary for some women sometimes as well.
Yeah. So I would, say, trust birth, whatever. But the really important thing is to build trust in yourself, in your intuition, and in your capacity to know what it is that you need. So that if birth does throw you a curveball, that you trust that you're gonna see that, and you're gonna be able to move with that and get what you need out of it. Because birth is, you really can't predict. But that's one thing I've learned as a midwife. If somebody said, what's your biggest, lesson that you've learned, it is you cannot predict birth. You just can't. So it's coming to terms with that, but really trusting yourself and your instincts. And different women will find different ways to do that. Some women will want to do that in groups. Other women will want, I don't know, to work with somebody specifically to do that. Other women will, I've heard women doing full-on exercise because they find that, running connects them with who they are and makes them feel capable and confident, and that's how they do it. So there isn't a prescription. It's, how do you build trust in yourself?
Be true to yourself, connect with yourself, and find what makes the experience work for you. That's what I love, that's what I love about this advice.
And what do you need to do that and access it?
Okay, well, I just want to ask you one more thing. I know I said that, but did you have any other anything else you would love to share with the audience in regards to a physiological VBAC home birth?
Not really. Just that, look, it's possible. More than possible. The chances are that if you plan to have a physiological VBAC, it will happen. It's more likely to happen than a woman planning to have her first baby physiologically. You've got everything you need inside you. You can do this.
Yay. Thanks. So positive. I love that. Thank you so much for coming on and sharing your wisdom and your expertise and your passion with us today.
It's my pleasure.
Thank you so much. Hey, me again. I just wanted to let you know that I've just created a brand new Facebook group called VBAC Home Birth Support Group, where you can connect with other like-minded mothers who are looking to have a VBAC home birth as well. You can find the link in the show notes, and I look forward to seeing you there. Thank you so much for listening to the VBAC Home Birth Stories podcast. I hope that this episode has helped you take another step to finding your voice and confidence in your VBAC journey. If you enjoyed the episode, please take a second to rate and review. Each review helps us to help more women to find out more about VBAC home birth, just like you. Don't forget to take a screenshot, share it to your Instagram stories, and tag me at the Motherhood Circle. See you next week.